Hello and welcome to this Wound Care Today Facebook Live seminar. My name's Dr. Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust and a researcher from the University of Huddersfield. I'd like to welcome you to today's session on embracing self-care solutions for patients who are suffering from venous leg ulceration. Within this session, we're going to start off just by reviewing the current climate in relation to the challenge many of us are facing in managing these patients who are suffering from this debilitating condition. And then we're going to move on to see how we can embrace self-care solutions as part of a leg ulcer pathway to improve outcomes for the NHS, for you as clinicians, but most importantly for the patients. Today's sessions may be a little bit different from some of the previous Wound Care Today live events that you've seen. We've asked you before this, over the last couple of weeks, to share your challenges and questions with us, and we've been delighted to receive so many of you who've been in touch, and we've got so many questions for us to be able to discuss. We've collected these together to try to group them into topics because many of them have got very similar themes. I'd like to just acknowledge that this seminar is kindly supported by L&R. As well as discussing the topics that we've received over the last week, we'll also have a session for a live question and answer event at the end of this session. So at any time during this seminar, you can submit any questions by commenting on the video below, and we'll do our best to answer as many of these as possible at the end of this session. After the event, you'll have access to your certificate of attendance, which can contribute towards your revalidation and also give you those vital continuing professional development hours that you require. But before we get into discussions, I'd first like to share with you some of the context to get us started really about this field of managing patients with leg ulceration. Many of you are aware of the reality of the situation, but this paper by Julian Guest and Kath and Peter Vowden really helped to articulate the size of this burden. At this moment in time, there's around 730,000 patients affected by active leg ulceration, and this equates to 1.5% of the whole adult population. And from this paper, there were some real problems in terms of the quality of care that patients were provided. It documented that only 16% of patients had a recorded ankle brachial pressure index. And many of you will know that this ABPI is the key to the door for compression. And it's rather unjust that 84% of patients out there don't even get access to the key to the door. And even if we do get things right, we've got huge problems in terms of the amount of patients that recur. There's recurrence rates reported within the literature of up to 69% at 1 year, which is massive. And when you put all of that together, the NHS really needs a solution for all of this. But I think every one of you will be able to recognise that actually patients deserve better than the current status quo. This paper though did a few important things. It helped to identify the true burden in terms of cost. And who would have thought that caring for patients with wounds and their associated comorbidities is up there in the top 5 spends for the overall NHS. This paper really helped to articulate this, not just to us as clinicians who can feel the size of this burden, but also to the payers and the commissioners of our services. And when we looked at the amount of wounds that we are caring from, it won't come to many surprise to you, especially community colleagues out there, that a third of all of the wounds which are chronic are actually affected on the lower limb. Many of you will be involved in the important education and awareness that's been happening in relation to pressure ulceration over the last few years. But as a vascular nurse, I've always been rather frustrated by this, that where we've only got 7% of patients suffering with pressure ulceration, we've got over 30% of patients suffering with lower limb ulceration. And thankfully, we're now starting to focus on the elephant in the room, that being those leg ulcers. And you'll have heard of the National Wound Care Strategy with the lower limb stream, trying to really focus and articulate what high quality care is in this stream, and also the Legs Matters campaign, helping to raise awareness to the patients about what good care should look like. And all of these campaigns and strategies are trying to really break this status quo. Because when we look at healing rates in the real world, only 47% of patients with a venous leg ulcer heal within a 12-month period. It's amazing when you start to read the literature that there are many randomised control trials out there relating to venous leg ulcers that report healing rates of greater than 85% at 24 weeks. How come we can get healing rates of 85% at 24 weeks in a controlled research trial, but in reality we're only healing 47% of venous leg ulcers at 12 months? And when you think about the burden in terms of the amount of money, this is costing £1.94 billion towards the NHS. This is a massive impact on the overall health budget. We all know that the NHS needs to reduce its spend. Within the forward plan and the ongoing 10-year plan, everyone's talking about trying to reduce the cost. And the figure that they ask us to reduce is by £30 billion. This is really difficult, especially as a clinician, because it feels like our caseloads are becoming more complex and our caseloads are growing day by day. But maybe we as clinicians just need to start to think differently if we're ever going to reach these NHS targets. If you think about some of the current issues that we are facing within leg ulcer services, especially community leg ulcer services, there is a huge amount of inconsistency. We have problems in terms of there is a lack of evidence-based care being applied to these patients. There is a lack of differential diagnosis. Patients are not told that they have underlying venous disease. Their venous system is not assessed. Patients are not labelled with that diagnosis. They're treated with wet legs or leg ulceration, but we need to think about that underlying cause. We've identified that there's far few Doppler tests being done. We need to ensure that patients are receiving adequate assessment and timely intervention, so therefore assessing patients within 2 weeks of wounding to see if they're suitable for compression therapy. We have huge problems in terms of inconsistency with the clinician's choice of dressings, the choice of bandaging and the choice of compression systems. And we have a huge problem at the moment in terms of the changing of our commissioners' services. There's a great debate going on at the moment of who should deal with these patients with these lower leg wounds. Should that be a practice nurse or should that be a community nurse? And surely that should not just be based on whether that patient is housebound or not. Surely that should be based on which clinician has got the appropriate capability and competency to care for those patients. So when you put all of that together, the NHS needs a solution. It's a bit of a mess at this moment in time, and patients deserve better. So why are we so bad at this moment in time? Well, there are many reasons. The first one is that unfortunately a leg ulcer is not recognised as a leg ulcer. Many patients are treated with lower leg wounds. If you had a skin tear or a traumatic wound, you can have a skin tear for 10 weeks. Nobody identifies that healing of that initial traumatic wound may be delayed because of venous hypertension or edema. There is a problem with the word ulceration as well, because many patients are scared of that diagnosis. How many of your patients have said to you, it's not an ulcer, is it? Somehow we have scared the public into not wanting to appreciate that they have an ulceration. But an ulceration is a good thing to recognise, because if at least we can recognise that, we can use evidence-based pathways to ensure that the patient is getting the appropriate timely care. Even if we've got the patient having recognised an ulcer, there's a whole problem in getting the ABPI measured. There are many reasons why this is not performed. The nurses haven't got the time, they haven't got the equipment, they haven't got the skill, they haven't got the competency. We need to get rid of the excuses and ensure that patients are receiving adequate assessment in a timely fashion. And even if you've got an ABPI, there's a problem with the interpretation of the ABPI. I hear so many clinicians say to me, their ABPI was 0.82, so I put them into reduced compression. An ABPI between 0.8 and 1.3 is normal. It's normal enough, therefore, we can apply full strength compression. It doesn't matter whereabout the patient sits on that range of that scale, they are still suitable for full strength compression. Even if you've got all of that, somehow there seems to be an issue with the confidence of that nurse making a diagnosis that this is a venous leg ulcer. Nurses out there will diagnose many things without any hesitation. Many of you will diagnose a UTI in a heartbeat, but for some reason you are scared to think about diagnosing the underlying cause of a leg ulcer. Please have the courage of your conviction. With the right education that you're receiving today, you will be able to improve your diagnostic skills. You know more about leg ulceration than many of the medical colleagues that you work with. We need to ensure that we're considering what is the underlying pathophysiology and how we address this. Therefore, if it is arterial of a diagnosis, have we thought about revascularisation? If it is venous, have we thought about venous intervention and appropriate compression? Even if we've got all of those right, we've still got an issue with the underuse of compression and the subtherapeutic compression. Patients with venous leg ulcers need at least 40 milligrams of mercury. Many patients require higher strength than 40 milligrams of mercury, but anything below this, to coin a phrase of my colleague, is tickling the leg. It is subtherapeutic, and basically you are elongating your patient's suffering and their time to healing. But even if we've got all of that correct, we still have issues in terms of poor compression bandaging techniques, like seen on this picture. If that nurse has put that bandage on not intentionally to look like that, she's done that because she hasn't got the competency or the skills at this moment in time to apply that compression correctly. And if your bandaging that you are taking off looks like this, we need to address that. That can be addressed by using other forms of compression therapy or by improving your bandage techniques. I appreciate that we have variations of national commissioning up and down the UK. But at least if we can do things, a collective of clinicians, to get sure that patients have appropriate assessment within 2 weeks of wounding, that they are assessed for their arterial insufficiency and their suitability of compression therapy within 2 to 6 weeks, and that patients who can have are in full strength therapeutic compression, we will really start to turn the tide on this management of chronic disease. Any chronic severe leg ulcer started off as a tiny wound. We have an opportunity in the first few weeks of that wounding to get things right, to stop this progressing, to stop this becoming a huge burden, both to us as clinicians, but more importantly to our patients. The evidence exists for all of this. We know that there is the best form of evidence. There are randomised controlled trials, systematic reviews and meta-analysis performed by Cochrane Group to say that compression therapy works. And you've all seen the power of compression, that when you apply therapeutic compression, you can get wounds that look like shark bite-sized ulcers to heal within a matter of weeks. But we need to start thinking about self-care as part of this solution package. What other type of chronic disease would you know of or treat with your patients that you do every intervention for them? Some of the interventions with lower leg edema and lower leg wounds can be provided by the patients and their families, and we just need to embrace that as an NHS. I'd just like to point out that we're going to be talking today about the use of compression hosiery kits. You can call these gold standard. This was due to a randomised controlled trial that was published back in 2014 that compared head-to-head multi-layer compression bandaging with 2-layer compression hosiery kits. They found that they healed as same in terms of times as a multi-layer bandage, but they cost less money, and more importantly, they reduce the risk of recurrence by around 9%. And the conclusion of this trial was, if we increase the use of compression hosiery kits, this is likely to result in substantial saving for the NHS and improve quality of life for patients with venous leg ulcers. And we just need to keep that high quality evidence at the heart of our conversations today. But me as a clinician knew about the Venus 4 trial for quite some time, but we appreciated that there were some barriers in trying to get this into everyday clinical practice. And that's my job as a clinician, as an author, and also as a researcher. So we needed to look at ways to removing the barriers for you to use this with every part of your everyday care package. Because when they've been proven that they are clinically as effective, they present a cost opportunity but also have a positive impact of the quality of life, why shouldn't we embrace those? And to help you embrace those, we appreciated that clinicians out there on the cold front of nursing needed some help and support in terms of translating that randomised controlled trial evidence into everyday practice. And many of you may have already seen and read the pathway that I produced with my colleague Joy Tickle a couple of years ago. This is just a simple flowchart. It helps you identify what is the best evidence-based care for your patients. It brings in the importance of appropriate assessment of the underlying venous insufficiency to look for areas of insufficiency that can be treated by a surgical, minimally invasive approach. It looks at the importance of embracing compression and especially trying to get patients to self-care wherever possible. This solution really places that early emphasis on getting that diagnosis right. It supports that use of compression from an early stage in that patient's pathway. It tries to embed all of that underpinning evidence into one simple flowchart that you can use on your clinic walls in the back of your diary to help ensure that you are providing evidence-based care. And it provides those self-care solutions first line for every patient. And more importantly, it helps to identify the importance of prevention of recurrence, because if we don't tackle that problem with 69% patients recurring every year, we're never going to win this war on leg ulceration. So, it's time now to answer some of the questions that you've posed to us over the last week, and I'd just like to introduce to you my friend and also colleague, Rachael Sykes. Rachael is a clinician, she's a nurse by background and she's got a massive nursing hat still within her, but she's also the marketing lead at L&R. Rachael.
Hi, thanks Leanne. Thank you so much for letting me join into this conversation. It's something that both you and I are very passionate about, so I feel quite privileged to be sitting on the sofa here and talking to you today. Normally we're just the two of us or a few of us in the room, not with so many people listening in, but I think it's really important that we're having this conversation with a big group, albeit not in the room. So thank you for joining us as well. Thank you also, as Leanne said, for submitting the questions to us. Leanne mentioned earlier there's lots of themes to these questions, so we've tried to group them so that we can answer as many as possible. But what I will say is we did get a couple of questions about specific patients, and while we want to support and we want to answer as best we can, it's probably not the right time to do it now within the session, but Leanne and I will envisage to get back to you to support you as best we can. But moving on to the questions that we've got to answer for now, and this is my first one for you, Leanne, which I think is a very important question so that we're all on the same page from the outset. There are a few questions that came in around what is a self-care solution, so what products exactly are we talking about within this discussion today?
And I think it's really important to clarify what we are talking about. When I talk about self-care solutions, it is options for patients, families, members of staff that haven't got core capabilities in compression bandaging, applying therapeutic compression. This, though, is not about people applying compression bandaging. This is using alternative solutions to get that perfect compression. So one of those solutions is what we discussed within the Venous 4 trial. It's using compression hosiery kits. The beauty of these compression hosiery kits is that the compression value is given within the garment. So it doesn't matter who puts these on, you will always get the most appropriate graduated compression. So long as you've measured your limb correctly and sized it appropriately, you will always ensure that you are getting that sustained compression. Another of the newer solutions that we've got in today's armoury is the compression wrap system. And this provides a really good solution, I think, for a certain group of patients that we'll go on to explore a little later.
Fantastic. So I'm really pleased that you mentioned before about not necessarily pigeonholing these products for patients who can self-care or people that have got family members or carers that can support them. These are really great solutions as well for clinicians to apply compression on a patient that's sustained, it's therapeutic and it's graduated. So it's great that it can be used throughout the whole skill mix.
Absolutely. And you've got to remember what the Venous 4 randomised control trial said. It said that these are as good as multi-layer bandaging, but they're cheaper. But not only that they prevent recurrence in a greater fashion. You also got to think about how quick can you put this on compared to a compression bandage. And also we've got to remember who our clientele is of today's world. If me or you were unfortunate to suffer from a leg ulceration, would you want compression bandage in place, which would restrict what footwear you can wear, restrict how you can bath and shower? I certainly wouldn't want that. I wouldn't want to be labelled by a big bandage that I have a medical condition. Would I wear this? Certainly would. It's discreet and it allows me to take some control back. I think it's really important in today's NHS that we identify that we shouldn't be taking all the control out of the patients. It's about giving the patients the ability to look after themselves. You've got to remember that many of these patients that we're talking about are going to have chronic edema. They're going to have chronic venous insufficiency. So this may be lifelong management. We need to empower them and educate them how to manage themselves. You know, should be first line. It's first line within the pathway that we use. It's first line within the clinic where we are. You know, patients love these, and it's brilliant to give the patient the ability to be able to care for themselves.
It's a great point, and I think it is about that patient empowerment, but it's also about challenging our own, I suppose, ritualistic views and ritualistic practice as clinicians. So, and we'll touch on that later, I'm sure, within the conversation. But just, you mentioned wraps and you mentioned hosiery kits there, Leanne. Can you just clarify when you would use a hosiery kit and when you would use a wrap within the care pathway?
So the first thing within the hosiery kit is not about whether you self-care or not, and it's not about who's looking after you. The first assessment we would do is obviously making sure we've got the appropriate diagnosis. We would then assess whether you can have full strength compression, ideally by using an ABPI, if not by using another form of arterial assessment. Once we've done that, we'll ask ourselves two simple questions. Is the exudate controlled within the dressing? If it isn't, then by default you are going to need extra absorbency, so you're going to need a bandage. If the exudate though is controlled within that dressing, a hosiery kit is you're getting closer to it. The next question to ask yourself though is about their limb shape and their limb volume. If you've got a large amount of edema, we may need a period of bandaging or wrap systems to be able to move some of that edema first. So they may not be suitable for compression hosiery kits in the first instance. Or if they've got a very unusual limb shape, you may need tailored bandaging once again. But if you've got a half decent limb shape with only mild to moderate edema within it and a wound where the exudate is controlled within the dressing, this should be first line for every patient. We should then be trying, once we've got this first line, thinking about, can you self-care or do you still need a nursing input? But your basis of using a compression hosiery kit should be based on those two things. If you have a high exuding wound, you're always going to need a period of bandaging. But if you've got a limb shape where you think you're going to have substantial limb reduction quite quickly, the compression wrap system can work quite nicely for those patients, especially those patients where you're trying to manage quite chronic edema in certain groups of patients.
How about scenarios where you want your patient to be able to self-care, or you want carers to be involved, but there's some slight difficulty in relation to applying the hosiery kit? Would you consider a wrap in that scenario as well to enable them to continue to self-care?
Yeah, absolutely. And I think for me, clinically, if a patient's got a wound, we've got to remember where the level 1 evidence sits within all of this.
Yeah.
And the level 1 evidence currently sits within compression hosiery kits and compression bandaging. There is a call for a randomised control trial, doing a head-to-head trial with these. At this moment, we should be aiming for compression hosiery kits or compression bandaging wherever possible. We've both met many patients in our career that will not tolerate either of those or are simply not suitable for those. So compression wrap systems are really useful. I use these a lot within my clinic to actually manage patients once we've got them healed. Because you will know many patients we can heal within a compression bandage. It comes to the point though that they no longer need a nursing input and they cannot cope with their hosiery going forward. Many of those patients in today's world, unfortunately, have difficulty touching their toes because of the rising numbers of obese patients that we're treating. Compression wrap systems are fantastic for that because they simply swip on the leg so you don't need to touch your toes. And we need to ensure that we are educating these patients that this is your disease, that you need to take some ownership for this and your well-being, and empowering them to provide their own care with such a garment is a great step forward.
Absolutely agree. So just to summarise, it's about clinical presentation in terms of leg shape, levels of exudate, for example, but it's also about the patient's ability, and also there's an element of choice in it at times as well.
Completely, and there should be an element of a greater element of patient choice, because if we have got evidence to say this is as good as that, surely it should come down to the patients to be able to say, what would you prefer?
Absolutely.
If we can engage the patients and giving them some power in terms of decision making, we've got a much better chance of them concording with us in terms of their long-term treatment.
Yeah, absolutely agree. So we've talked quite a bit already about patient engagement and empowering our patients to embrace self-care. This is a really relevant point that came in from one of the audience. I would love to embrace self-care. However, most of my patients certainly would not be able to apply their own wraps or hosiery. Do you have anything to add to that? Anything to say, Leanne?
Yes, there's many things to say about that. What I'd say is I think that that's your individual belief system that you are pressing over to your patients. And it depends on how you're selling it to your patients. The first question I'd ask you is do you really know how to put one of these on? There are hints and tips how to put this on and an appropriate way to put this on. Once you've got this knack of how to apply this appropriately, it's dead easy to do. I know there's some great support videos within the LNR websites that shows you how to do this. But once we've got that, then we can really think about how easy this is. I think it's about thinking about your patients. How are you educating your patients? How are you engaging with your patients? And the first thing to get across to your patients is the importance of the underlying disease. Don't sell this as we need to squeeze your leg. Talk to them about the venous hypertension inside that's causing that chronic inflammation and chaos behind that wound, and the fact that we need to calm down that chaos to be able to get that wound to heal. If we talk to patients in that way, very quickly we'll be able to get them to identify the reason why the need to try with these garments or these compression wrap systems to get that wound moving forward.
Can I just ask you to, there's a patient that you've talked to many of us about before, a lovely lady that I think really challenges our own perception and view of self-care, and I think it's a great story to share with the audience that will help maybe other people challenge their view on who can self-care.
Yeah, so hopefully you're going to see a picture coming up with you of one of my very wonderful patients. Her name is Sheila. That's her real name. She's given me permission to share her name and also her picture with you today. This lady's had spina bifida as a child. She's been in a wheelchair the majority of life and she suffered from a lower limb ulceration. Years ago, when she started with this leg ulcer, this started to ruin her life. As having spina bifida, she's never had anything ruin her life. She's an extremely independent and feisty lady, proper Yorkshire lass. And she was doing everything independently. Then all of a sudden she had a break in her skin. And all of a sudden we're telling her that you need to come to clinic twice a week to have your compression bandaging changed. She didn't want to come to clinic twice a week. She couldn't get there. Clinic was half an hour away in a wheelchair. She didn't want hospital transport because if you're on hospital transport, you can wipe a day out of your diary. So she came to my clinic and said, you must find a solution for me that I can do this myself. And we provided her with some compression wrap systems and she was able to reduce her edema beautifully well. And if you look at Sheila's picture, you might think, I bet she had support at home. This is her husband that's flashing up now, and you can see by his face he didn't give his permission to be able to be shared with you today, but Sheila did, and Sheila rules the roost. He also has spina bifida and has been based in a wheelchair for quite some time. Between them, they can manage these compression wrap systems beautifully well. And it's about thinking about our belief system and thinking what we perceive patients can and cannot do, and actually what they can do. I also think it's the way that you sell it as a nurse. If many of you are thinking about embracing self-care, self-care means a patient actually looking after their own wound. And if I say that to you, many of you will go, my patients won't look after their own wound. That's simply because at this moment in time, you haven't given them the option. You are seeing them twice a week and they're expecting you to see them twice a week. What if, though, you provided that patient with a compression hosiery kit and 6 weeks worth of dressings? Off you go, I will see you in 6 weeks. If a patient doesn't know any different, you can simply say that's a service that we now offer. And I think we need to really embrace this at the NHS. What difference does a wound change from day in, day out, day in, day out? So long as you're educating your patients of how to do hand hygiene, how to manage a wound. What are the red flags in terms of signs of infection that we want them to report back, and have some form of mechanism that they can SOS to come back to see you urgently What's wrong with expediting these patients out and only seeing them every 4 to 6 weeks?
Absolutely.
And when we talk about self-care, we need to ensure that we're giving patients not just verbal empowerment, but also written empowerment. And I know me and you've come across this before, but this is the leg ulcer pathway, the passport that we've created. And within that, we can identify their pathway of care, their treatment plan, and also it tells them how to care for their own wound. And it also tells them about the red flags, what they need to worry about and how they need to escalate back to us. Providing patients with important documentation that really empowers their ability to self-care is extremely vital.
No, absolutely agree. So again, it's about giving the patient the right tools in terms of education, in terms of the right product, but also kind of supporting them through that empowerment.
Absolutely, and it's about the right level of support. The right level of support does not mean the nurse changes the dressing for each and every dressing change.
Absolutely. Now, linked to that, you've actually answered my next two questions, which is great. But linked to that, we know that we can use wraps and hosiery kits to deliver self-care in terms of compression or to support the patient to deliver their own care. What types of other products would you recommend to be used under the wraps and hosiery kits? Because that question does come up a lot. So what dressings, for example, would you recommend?
Well, you've got to remember that there is no evidence to support one dressing is better than the other. The evidence says that all you need is a low adherent dressing. And that's the evidence base. And remember, I'm both an academic and a researcher, but also a clinician. And as much as the evidence base may say that, I know for many patients with leg ulceration, we also need a degree of absorbency. We need to be careful of the surrounding skin using adhesive products because we need to assess the surrounding skin for likes of venous eczema. But if you've got a wound with a quite healthy surrounding skin, using some form of low adherent dressing with maybe an adhesive border can be really helpful because that keeps the dressing in place to allow the compression hosiery kit to slide over the top of it. But when you talk about which product, it's more to do with your wound bed preparation in terms of tissue, whether it's necrotic or sloughy. Is there any signs of increased bacterial burden? What's the moisture level like and what you're trying to do with your wound edges? But there are many wound products out there that are suitable to be used under a compression hosiery kit. What I'd say though is if you're looking for circumferential leg ulcer dressings, that's the time that I'd be thinking, is the leg ulcer hosiery kit the right thing for you? Absolutely. Because if you're needing that amount of dressings, should you be using compression bandaging or compression wrap systems? For me, these are best on when you've got one or two areas of ulceration that you can get a nice dressing to cover all of that area.
Absolutely agree. I think another barometer that I think is often quite useful as well is if you are assessing that you need to use a super absorbent dressing, for example, because of the levels of exudate, that would set your alarm bells ringing straight away that a self-care solution like a hosiery kit or a wrap isn't the best solution for the patients. You'd step them into a bandage routine. Also as well, if the exudate levels reduce and your patient, you can then step them down from a super absorbent dressing, then it's maybe time to think about stepping the patient down into a self-care solution as well. So using that dressing choice as a barometer.
Completely agree. If you're requiring large amounts of super absorbent dressings, that should be a large alarm bell ringing within you. But you're exactly right, Rachel. As soon as you have the exudate controlled within the dressing and the limb shape of a normal size, you should be trying to step your patient down into a compression hosiery kit. And the reason why we want to do this is that you're going to be brain training that patient about their underlying disease and the requirement for therapeutic compression on a long-term basis to manage their venous hypertension. And we know from the results of the Venous 4 trial that you can reduce your risk of recurrence by doing that degree of brain training with your patients.
Absolutely. Another, again, linked to this, I think a very relevant comment that came in from the audience in advance, and I think a lot of people will identify with this, is that patients are often reluctant to transition from bandage to hosiery. We don't know whether that's before or after healing due to barriers such as patient comfort and their ability to apply compression. Are there any hints and tips you can give there to help that transition?
And it goes back to talking to your patients, educating your patient of the requirement for this. Many patients just don't understand why they need compression. They see that they need a dressing and they see that they need a bandage because they've got a wound. But as soon as that wound starts to progress, they have no link of why do I need this going forward. And it's about always bringing it back to that underlying pathophysiology. What are we trying to treat? Educating that patient about the requirement of this. And the fact that if we don't have sustained compression, if they have venous disease that's non-correctable from a surgical approach, they have got a high chance of this coming back. So therefore we need to ensure that they've got sustained compression to keep those venous pressures low, to keep that edema at bay. So it's all about really thinking about our barriers. I know Eleanor's got a fantastic video about a 99-year-old grandmother who puts on a compression hosiery kit better than me. We've got to think about, is this our belief that they're not going to be able to manage, or is actually what the patient's reporting back? And it's also looking at solutions to that. Aids, adaptations, glide systems to be able to get these on, donning and doffing systems. There's lots and lots of applications and aids available to our patients. We also need to think about, have we got the right garment on?
Absolutely.
If it's finding that it's wrinkling or uncomfortable, have you got the right knit, the right strength, the right classification of stockings to keep that at bay? Think about the fit. It's a great bugbear of mine that we are measuring patients and supplying them compression hosiery, but who does that first check of that fit of that stocking? And if you're identifying a problem, it's at that point you should be saying, okay, this is not ideal for you, let me remeasure, let me re-prescribe. It's so vital that we get a garment that the patient feels comfortable going forward long term.
I absolutely agree, and we know there are tools available to facilitate that, and there will be information afterwards that you can access to give you some guidance and support with those tools. I think it's at the foundation making sure that we've got the right product for the patient.
Absolutely.
Because that will help them with that kind of transition from bandage into hosiery or bandage into wrap at whatever point appropriate. But if we can do that whilst the patient's still got an active ulcer, you're supporting them more at that stage, so you can iron out any problems whilst the ulcer's being treated, and then once they're healed in the maintenance stage, they're much more likely to get on better and reduce recurrence in the long run.
Absolutely, and remember that you only have access to a nurse while you've got a wound, so we've got that window of opportunity while you've got a leg ulcer. Once you're healed, the nurse will start to disappear.
Absolutely.
So it is absolutely vital that we get the right garment while we've still got that informed, educated individual in terms of that professional seeing that patient.
Absolutely. There's a very specific question that's come in, but I also again think it's very relevant and people will be able to identify with this challenge. One clinician has submitted, I have a patient with late stage dementia who was unable to sit still. What would you advise, Leanne?
Management of patients with dementia is always complex, and it depends what element of their dementia they're struggling with. So there's many types of dementia traits. If the patient is struggling to sit still, actually using something like a wrap system or a hosiery kit is actually good because it's a quicker application. So therefore if the carer can distract the patient, you can get this on a lot quicker.
Yeah.
But it depends whether they're a twiddler or a fiddler. And if they're a twiddler or a fiddler and they like to roll down the stocking and play with the stocking, sometimes stockings may not be the right solution. But I'll tell you what's really good, the compression wrap systems. Especially, we've heard that other clinicians are putting this on backwards way round. So actually the Velcro straps are at the back. And because the patients with dementia can't actually see them on their leg, they're leaving them in place because all they can see is the garment from a front. I think that's a great tip to be able to consider. Management with patients with dementia needs to be individualised.
Yeah.
You need to be linking with your dementia leads within your organisation about what strategies you've got in terms of managing their dementia. But you just need to think out of the box. It's about thinking how you can get sustained compression on that patient and thinking how they're going to keep it on and not push it down or remove it. Whichever system, the bandaging, the wrap system or the compression hosiery, who cares really, so long as they've got some therapeutic compression in place.
Absolutely, that was really useful, I'm sure, for whoever submitted that question. This is the final question of the pre-submitted questions, Leanne, and I think it's a great question to finish this section on. A lot of nurses that I work with are not willing to take a step back and encourage self-care. What can I do to show them that self-care is the way forward? And we agree, here.
Yeah, so when you think about self-care, what we're talking about really is lengthening the leash we have currently on our patients. At the moment, many patients will be dabbling with self-care, and clinicians will be dabbling with self-care, and many of us are dabbling because we haven't got capacity within our services. So therefore, many of you will be saying this patient needs changing the dressing twice a week. I'll do a Monday. Patient or family, can you do the Friday? And I'll just see it every Monday. what are we doing here? Many of our nursing services, especially community nursing services, are at full stretching point. We need to look at other solutions of what we've got. If you can inform the patient, educate the patient, give them the safety requirements to be able to self-care, we need to be embracing this. Absolutely. We need to be giving that patient 6 weeks of dressings. Cheerio, I'll see you in 6 weeks. At that point, you can do a proper reassessment. Has this wound changed or not? A wound doesn't change within 3 or 4 days, but within 6 weeks, you will see whether that wound's on a healing trajectory or not. There's always going to be people within your teams that are going to be late comers to change. And I think it's about looking at what's in it for them. And to me, I would be talking about asking those nurses, do you get a lunch break when it's uninterrupted? Do you get a cup of tea? Do you get to go home on time every night? And I don't know one nurse that answers yes to all of those questions. So you need to think about what's in it for them. We have great evidence, especially locally, that by embracing self-care solutions, we have reduced the impact on our district nurse services by 60%. 60%. What would that mean to a nurse out there? 60% more time. Maybe it gives them a little bit more time to care for the patients, to do the job they love, to go away from feeling like it's a task-orientated job that they're getting and give a little passion back into the role that they're delivering. So I think it's about talking to the ones that won't change about, why did you come into nursing? What do you want from nursing? What are the barriers to you giving high-quality care at this moment in time? And every nurse will say, time. Well, here's a solution to time. Let's embrace everybody we possibly can to self-care. Let's concentrate those that really need nursing input. If we can move these on through a self-management system, isn't that win-win for all?
Absolutely agree. And I have to say thank you to whoever submitted this question, because it's great that you're wanting to help your colleagues take that step forward. It can be quite a big step. It's a big leap for some people to challenge practice. But if you can lead by example, if you can be that change agent within your organisation to show people how it can work and how it can make a difference for patients, then absolutely it's the right way to go.
And you know, collecting local audit data is really valuable. So if you are making these changes and you can show local change in terms of how many nursing contacts they've got, how much nursing time's involved, if you're able to collect that as one small team, cascade that throughout your services, many people will look at your local audit data and think, wow, this is replicable because it's been done locally.
Absolutely, yeah, absolutely. And that's happening in some trusts nationally. There's some great work going on, so it's about us all sharing best practice and us all benefiting from that, absolutely. So that's the end of our pre-submitted questions. We're going to move on to the live question and answer session now. So let's see what questions come in. You can still take part of this by commenting on the video at the moment, but let's move on to our first question that we've got. So this is from Demi. The phrase I get on a daily basis, which comes to me crazy, is, can you not do it tight? What's the best way to work with these patients?
I am a ferocious bandager. I've checked my some bandage pressure measurements and I'm well above 40. I have this a lot, especially when patients have been within community services where they may not have had such a competent bandager or a ferocious bandager, or tried to listen to the patients, therefore just lightened off on the bandage. I think it's about talking to your patient again of why are we doing this? What are we trying to treat? And it's talking to them about, you know, I appreciate that this is going to feel rather tight, but it's talking to them about, let's think about the venous hypertension that's happening inside. Let's think about that chronic inflammation, and let's think about that chaos behind that wound. If we don't solve that by this therapeutic, tight compression, this wound is not going to get any better. So I appreciate that you may feel this tight, but what we need to do is to get the patients to work with us by understanding that pathophysiology, by saying, yeah, it might feel tight, honey, but this is the quickest way to get this wound to heal. We also need to remember that we have other solutions. So elastic bandages may feel tight. And if you've got a patient that doesn't like the tightness feel, one great thing to use is short stretch bandaging, because short stretch bandaging pressure, as soon as that patient elevates their leg, the pressure within that short stretch bandaging reduces substantially. So if you talk to your patient to say, we're going to put you on a short stretch system, if it feels too tight for you, elevate your leg. The pressures will reduce substantially, it'll feel a lot more comfortable for you. From a clinical point of view, win-win. We've got elevation, we've got reduced venous hypertension, and we've also got a contained bandage system. So it's all about how you sell it to the patient and how you engage that patient.
Absolutely great. And so can some of these patients be stepped down into a self-care solution?
Completely. And you know, some patients find compression hosiery feels more comfortable because it is more ergonomically designed to fit around that leg.
Absolutely. Now, this next question is coming from Joy Tickle, who was co-author of the pathway that Leanne talked about. Do you agree that it is even more vital to encourage and support self-care for venous disease, as this condition is for life and most patients actually do not want to be reliant on healthcare services? Couldn't agree more.
Completely, Joy. And me and you have had the same conversations quite a few times now. Absolutely. And this is all about empowering that patient to manage this lifelong condition. Remember though that with venous disease, there may be correctable solutions. So any patient with a venous leg ulcer should undergo a venous duplex scan to look for anatomical variations within the superficial venous system to see if they are correctable by minimal intervention. If you're able to operate on them, you will be able to reduce the chances of the leg ulcer coming back and shorten your time to healing. However, not every patient is suitable even for that minimally invasive surgery, because many patients have got functional venous disease, so problems with the calf muscle pump or the foot muscle pump. And for those patients, absolutely, compression therapy is a lifelong approach. And why should you be reliant for the rest of your life? And I go back to any other chronic disease. If you've got diabetes, if you've got Crohn's disease, if you've got COPD, we empower the patients, we educate the patients, we ask them to manage their own condition. We should be doing the same thing with chronic venous disease, with lymphedema and with chronic edema.
Absolutely great. I think we should be looking in a more meaningful way at other chronic disease models, because I think we can learn a lot from that.
Yeah, and that's where the patient passport came from, if you can remember. It came from other areas of chronic disease management, and there's great evidence base to say the use of patient passports within chronic disease management empowers patients and performs better health outcomes.
Absolutely. So another question has come in from Thea Rigby. Any tips to help patients applying leg ulcer hosiery kits? Some find it extremely difficult.
Yeah, there are lots of hints and tips. The first thing is learn to do it right. Many clinicians and patients just try to pull it on. You need to do it right in terms of grabbing down, grabbing the heel, turning it inside out, remembering when the heel is, rocking it back and getting this right on the foot, as low as down as your toes, pulling it up the foot and then coming up the leg. If you get the application of these correct, they are a lot easier to put on. And many patients come to me and go, flipping it, you put it on easy. And it's simply because we put it on the right way. And we also need to think about, some patients won't be able to completely self-care, but can we use other type of services? If you've got a wound and you're putting a patient on a compression hosiery kit, even if the patient can't manage this, does this allow you to send a HCA, a healthcare practitioner out, rather than a registered nurse to do that wound care? Non-registered workforce are the future of nursing. You know, we've got a great wave of change coming with nursing associates and apprentice nurses. I say hallelujah to that because I'm quite an old nurse. But thinking about embracing those, you know, they can be applying and removing their leg ulcer hosiery kits for these patients without any requirement of any further additional training in terms of competency, in terms of compression bandaging. But it's also looking at, is there any application aids that can help those patients? There's loads of them out there, some of them good, some of them bad, and some of them really useful. I know you've got some on your website. There's also, if you look at the Legs Matters website, there is some additional support on there in terms of all the ranges of applications that we've got.
Absolutely. Just one thing, I don't know whether the camera can see me now, one thing that I would say that was a really valuable hint and tip for me is And I often see other people doing it. Often what we tend to do when we're applying hosiery is bunch the product up like this. And what you're actually doing is bunching all of that compression up and making it quite difficult to apply. It seems sensible to do it because people do it with their socks often. But if we can avoid telling our patients to do this, it will make life much easier. And as Leanne said, there's video resources that we can signpost you to when you download your certificate to help you with those application techniques. But also as well, some of these patients that absolutely can't apply their own hosiery kits, if you want to enable them to continue to self-care, it may then be that a wrap might be the right solution for that patient as well. It's just happening to what's right for the patient, isn't it? So next question from Dawn Richardson. Do you think that empowering patients can lead to greater compliance, Leanne?
Yeah, we could have a whole debate on the word compliance, concordance and adherence, but we won't go down there at all. Absolutely. This is about patients taking responsibility of their own health and how to manage their own health, especially their long-term management. And, you know, many of you will be out there. We have a few what I would call simple venous leg ulcers out there. So a normalish looking leg on a normalish looking individual with a small ulcer. Those patients we can manage really quickly and really easily. But many of you will be dealing with complex patients and complex legs. Legs that are rather distorted in limb shape. Legs where you've got chronic edema that's attached to a patient with a really high BMI. There is nothing you're going to do to make that leg of a normal shape and a normal size. We can minimise the effect by trying to control the amount of congestion in that leg through compression. But if we're going to be bandaging those types of patients, we're going to be bandaging them forever. So we need to really empower that patient to take responsibility for their own health. This, hopefully, if you empower them and use motivational interviewing type techniques, you can make them make big lifestyle changes. Because there is no point in managing that chronic edema and that ulcer in isolation. We've got to think about the patient behind it. How are we getting them more active? How are we getting them to reduce the weight? How are they getting to live a more healthier lifestyle? And empowering the patient using motivational interview techniques is the way forward with those groups of patients.
Oh, really useful, thanks Leanne. And our final question of the evening from Kathy Kelsey. Once an ulcer heals, how do you decide what level of compression hosiery you would advise for long-term maintenance? Really good question.
A really good question. I think it comes for two things. I think as a vascular nurse consultant, what I'd say to you is every patient with a venous leg ulcer should have some form of venous imaging to see if they have correctable disease by minimally invasive surgery. So every patient should have that type of venous duplex scan to be able to look at that. But once we've got that in place and we're thinking about can we correct them, many patients will require lifelong compression. And it's about thinking about the appropriate amount of compression. The research evidence tells us that we should be using the highest compression possible. And that is actually said class 3 compression. But when you think about class 3 compression, it's extremely strong and we'll get potentially more problems in terms of the application. What's really, really useful, I think, is some type of evidence-based checker tool, like the one that LNI uses, that signposts what type of compression at what level you should be using. We know that there is huge problems in terms of manufacturers using both British standard and European standard. And we know that European standard stockings tend to be a higher value of compression than the British standard of stockings. All of that is really confusing for a clinician. But this type of chart that pinpoints what are your symptoms, what does your leg look like, what's your edema been like, what classification of stockings should you be using is really important. I also think it's really good in terms of identifying what type of knit we should be using. We've seen many patients that you reduce their congestion of their leg through bandaging or compression wrap systems, and you put them into a standard stocking and the edema will just rebound back. We need to be thinking about using flat knit stockings, appropriate stockings for that level of edema to keep that limb at bay. And the tool like this identifies all of that. Compression hosiery choice is complex. Use simple guides wherever you can, but I also know there's lots of great learning resources out there to try to identify what you should be using where.
Thanks, Leanne, thank you.
So, I'd just like to say thank you. I'd like to conclude today's discussions just to say thank you. Thank you for spending your valuable evening here listening to us. Thank you for your questions. It's been really informative for us to read some of the questions, and we're going to spend the next few hours trying to answer any unanswered questions we possibly can. I'd really like to take this opportunity to thank L&R for their continued support, for the support of really changing the national platform of leg ulcer care. I think it's fantastic that we can do educational events that's based on science, evidence-based and best clinical practice, rather than which is the best product. All you've heard today really is about the evidence base. It's about that appropriate assessment. It's about that timely compression of that therapeutic value, but giving patients solutions of what are they going to manage to use on a long-term project. So if you'd like to access your certificate of attendance, you need to follow the link that's on the screen now. That will link you to be able to print out your certificate that you can put in your portfolio to be able to link back to your revalidation and also claim your CPD points. I hope that this session has been useful to you, and I hope that you found some of the information that we have provided to you useful and also informative. What I'd just like to say to you really is that you as healthcare clinicians are a fantastic group of people. You have a real opportunity to care for your patients, and you're in this job not for the money and not for the glory. You're in it to make a difference because you have a true nursing heart. Think about embracing the self-care solutions because it will start to release some of your valuable time that you've got that was so precious to you at this moment. So what I would say is join the leg ulcer revolution, embrace the self-care solutions and start to release your time back to caring. Thank you so much. I hope you've enjoyed this event as much as we have. Don't forget as well to like the Facebook page and have a look for any of the upcoming events. So thank you very much for your time, and let's make the change. We can together start to make a difference with leg ulcers. Thank you.